You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 2nd, 2021. This week, COVID, long COVID, the language of medicine, trade-offs, and open notes. I walked through our ICU yesterday and saw just one name on the board that was written in red, signifying a COVID-19 positive patient. One. But I realized that COVID is a regional problem. The state of Michigan, the city of Paris, and the country of Brazil continues to struggle with the virus. There was vaccine news this week. On the positive side, the hospitalization curve from Israel continues to plummet lower, and this seems important because it provides real-world confirmation of the vaccine trials. And secondly, the Pfizer vaccine trial in 12 to 15-year-olds was reported as extremely favorable, though it was just a press release. But on the negative side, journalist Sue Hughes has news coverage of a European Medicines Association, EMA, press conference on reports of clotting disorders occurring shortly after the AstraZeneca vaccine. Quote, EMA is of the view that the benefits of the AstraZeneca vaccine in preventing COVID-19 with its associated risk of hospitalization and death outweigh the risks of side effects. But it adds, quote, vaccinated people should be aware of the remote possibility of these very rare types of blood clots occurring. Now, a preprint from a German group reported on clinical and laboratory features of 9 patients, 8 of whom were women, in Germany and Austria who developed thrombosis and thrombocytopenia after they received the AstraZeneca vaccine. The researchers' findings suggest that the vaccine appears to be linked to a condition that clinically resembles heparin-induced thrombocytopenia, or HIT, and that it occurs mainly in younger women. Now, this news has come out late Thursday afternoon, and I don't want to say too much more. I need to read this study more closely and see what others say. But given the slower vaccine rollouts and rising cases in the European Union, this seems like highly pertinent news. And vaccine science, of course, isn't directly related to cardiology, but 3 issues makes this notable. First, clinical trials designed to test efficacy of any therapy may not reveal rare adverse events. That's why you need real-world surveillance. Pacing and ICD lead failures are an example. Rare events have a base rate in the population, so these clotting events therefore may associate in time with the vaccine but may not be caused by the vaccine. And third, as per Kahneman and Tversky, behavioral psychology holds that humans don't always maximize decisions based on pure probability. So even though the net benefit may favor taking the AstraZeneca vaccine, the chance of a fatal, severe, rare event looms large in many people's minds. The possibility of rare events greatly influences medical practice. That's why it's hard to get out of an emergency room without having a CT of the chest to rule out PE, or a CT of the head to evaluate headaches. People are worried about rare events. Second topic is long COVID. Well, I've got an essay coming soon on one aspect of long COVID that really worries me. That is medical iatrogenesis. While I love being a doctor because we make a living helping people, stop and pause for a moment about the idea of sending millions more people into the current healthcare system. Now, if the base rate of harm is even a small percent, that means many of these millions will be harmed. I see 4 main factors driving medical iatrogenesis from long COVID: good intentions, uncertainty, the incentive to action, and of course, fear. Let's start with fear. The intense media attention and its concentration on anecdotes creates a social learning milieu in which people learn to be fearful. Also, the NIH announced it will spend billions on research for long COVID, so look for even more attention from academics. The presence of fear shreds good medical decision-making. Second issue, good intentions. Clinicians want to help. It's normal. And there are two basic ways that we demonstrate our caring signal. One is by listening and expressing empathy, but that is hard. Much easier is to just order tests. And that, my friends, sets up the potential for downstream cascades. Third issue is uncertainty. Now, I've reviewed many of the studies documenting long COVID, and here is a major flaw. Most of them sample patients from post-acute COVID clinics, or they use social media messaging like, if you consider yourself a long hauler, let us know about your symptoms. This is classic selection bias, where you're just sampling the population most affected. It doesn't allow you to get a good estimate of the prevalence of this condition. Another puzzle with long COVID are studies that find symptoms, except of course loss of taste or smell, are similar in patients who've tested positive versus those who've never had a positive test. That's peculiar. While testing in the pandemic was not always available, there's a finite fraction of people with long COVID symptoms that never had infection with SARS-CoV-2. And then finally, incentives. In the United States, everything is set up for doing more, not less. A cardiologist faced with a patient with fatigue months after COVID makes more dollars if she or he orders an echo or monitor and then reads those studies. And of course, at the hospital level, post-COVID care clinics help capture market share. So in the essay, I offer my solution to this problem, but I won't give it away here. Please go to the heart.org Medscape Cardiology probably next week to read it, but the teaser is that my solution for this has to do with an empirical, medically conservative, and humble approach to patients with real symptoms. Third topic is the language of medicine. This podcast has commented often on the linguistics of medicine. Congestive heart failure, for instance, is a terrible way to communicate with patients with chronic heart disease. Well, there's also an ongoing debate in the world of nephrology. In 2019, a group of experts convened a consensus conference, spending many hours talking and writing, and came up with the advice, use the word kidney rather than renal or nephro. As a seasoned doctor, I've often been corrected in the hospital. John, we don't say renal insufficiency anymore. It's chronic kidney disease stage whatever. Last month, a group of nephrologists pushed back and recommended keeping renal and nephro, especially in the academic literature. Renal replacement therapy is okay to say. It doesn't have to be kidney replacement therapy. I guess I would ask, perhaps stupidly, what about simply saying dialysis? Now, you learn from the news story and links that kidney is quite an English or Anglo-based term. For instance, kidney in French is L-A-R-E-I-N. My take here is that, okay, some revisitation of terms is reasonable. I mean, in the same way that heart failure is awful, so is end-stage kidney disease. But we should also be mindful of the concept of distraction. Time spent on the minutiae of syntax is time not spent on important things, like finding better therapies to help patients with kidney or renal disease. Economists call this opportunity cost. To wit, imagine the benefits if all the time spent speaking and writing and submitting manuscripts with the correct format for the journal X was spent on teaching clinicians about the SGLT2 inhibitor trials. In AFib clinic, I often see patients who have CKD and diabetes, and too often they are not on SGLT2 inhibitors. To me, this is a bigger crisis than any linguistics. And another thing that worries me a lot more than the language of kidney disease is the lack of trials in these patients. So bandwidth spent on language is bandwidth not spent on doing more trials. Maybe you disagree. Let me know what you think about this. Next topic is childhood obesity. The journal Pediatrics published alarming findings on the rates of childhood obesity during the pandemic. Now, this was an observational descriptive study from a large primary peds network in Philadelphia. Nearly 170,000 patient visits in 29 urban, suburban, and semi-rural clinics. The researchers measured average obesity rates during the 6 months pre-pandemic versus June to December of 2020. Overall, obesity prevalence increased from 13.7% to 15.4%. This increase was more pronounced in kids who were Hispanic, Latino, non-Hispanic, Black, publicly insured, or lower income. Figure 1B in the paper was super discouraging. It showed the rates of obesity by ethnicity. Now, first of all, I did not previously know that Latino and Black kids had nearly double the rate of obesity versus white kids, 20% versus 11% in this practice. But they do. Then, when the pandemic hits, the rates of obesity in both groups go up, but it goes up more in the Latino and Black kids relative to white kids. The authors succinctly write, quote, "Pre-existing disparities appeared to have worsened." Perhaps it's worth repeating that. Pre-existing disparities appear to have worsened. In the discussion section, the authors discuss why this would be. Efforts to reduce COVID-19 transmission have likely contributed to worsening pediatric obesity. They write, families with children have faced the difficulties of managing virtual schooling, limited physical activity, increased reliance on more heavily processed and calorie-dense foods. Okay, some comments. The first thing to say is this. Very early in the pandemic, everyone agreed that COVID-19 had an extremely steep age gradient, and thankfully SARS-CoV-2 essentially spares children. Now to why this research letter makes the podcast. It's because it highlights the important concept of trade-offs. I often say to patients, no intervention comes free. We must always consider the downsides. And there are many tragedies of this pandemic. The death toll, of course, is terrible. And what I'm about to say does not minimize that. For example, you can think cancer is a terrible disease and also think some cancer therapies are also terrible. But as we study this pandemic, and the passage of time permits discussion, I predict more and more papers like this will chronicle the truly tragic effects of our interventions. Now, as an adjective, I looked it up. Tragic means causing or characterized by extreme distress or sorrow. Well, given that this virus poses no more of a threat to kids than any of the other pre-pandemic respiratory viruses, it is extremely distressing and sorrowful that children bared such a heavy brunt during the COVID-19 mitigation. Even worse, though, and especially regretful, is how the mitigation worsened the pre-existing disparities between rich and poor kids. I don't know how you look at this data in this paper and not come to the conclusion that COVID-19 mitigation worsened structural racism in healthcare. This, to me, is an utter failure of American public health decision-making. Rich kids went to private schools and poor kids suffered. Now, it would have been understandable to allow these errors in the first few months when information on the virus was sparse. But public schools in many American cities remain closed or in person 1 day a week, which is crazy, a joke. The analogy in clinical medicine would be something like this. Your patient has a low-grade, slow-growing cancer, but you so fear that your patient is going to die of that cancer, you give strong chemotherapy, which does reduce the cancer a smidge, but causes severe damage to the heart. In other words, you tried to help, but you didn't pay enough heed to off-target effects. It shocks me that with all the attention paid these days to improving healthcare disparities, we let that COVID case ticker blind us to the harms our interventions are doing to those with less resources. My friends, always think about the harms of your interventions. Diseases can be bad, but so can our attempts to help. The final topic today is on open notes. Next week, a new U.S. law kicks in, allowing patients to have free, full, and immediate access to their clinicians' notes. This was part of the 21st Century Cures Act. It's sort of been going on for months, so I don't think next week will bring a rush of patient queries, but this story deserves a few words because it is a significant change in how doctors and patients interact. Obviously, the old way of jotting a few illegible notes in the chart with pen are long gone. And this podcast has commented often on the negative way electronic health records have influenced the patient-doctor interaction. But on the matter of open notes, I mostly think it is a net positive. My practice is to show patients what I write in the chart. I don't type very well, so it has to be short writing. My view of patient notes has changed over the course of my career. When I was in training and younger, I favored these long narratives about the differential diagnosis and why this or that was more or less likely to be the cause of the problem. But once I got in practice and I learned from master clinicians, no single person was ever healed by words written in the chart. And the more time you spend in charting, the less time you spend with people at the bedside. My take of using words in the chart now is to use the minimum needed to convey the medical information for colleagues and the minimum needed to support billing. One of the criticisms of the Open Notes initiative is that it will inhibit some of the nuance of medical communication. For instance, if you know a patient can read the chart, you might be hesitant to write certain things. And I understand that argument, but I don't quite agree. As a person who likes to write, I think you can convey important issues in clever ways. For instance, instead of saying someone is non-compliant with their medicines, I like to cite the patient who says, "I adjust my blood thinner according to how much bruising I see." If you write that as a quote, the reader understands that the patient is non-compliant. Another advantage of Open Notes is that it helps us clarify reporting of our test. For instance, when I read an ECG monitor now, I will clarify that the usual non-specific atrial tachycardias that we see in older patients are, quote, not clinically worrisome. In the end, making medical information more transparent, reducing jargon, and involving the patients with their data seems to me a net positive. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, friends, please, if you like this podcast, it really helps to give us a rating and write us a review. That way others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.